Hi everyone, I'm Dr. Jeewat Ram. Today I will discuss about celiac disease. Celiac disease is an anti-inflammatory autoimmune condition of the small intestine triggered by gluten in genetically susceptible individuals. It has diverse multisystemic clinical manifestations rather than being a primary intestinal disease. Other terms for celiac disease include gluten-sensitive enteropathy, nontropical sprue, and celiac sprue. Epidemiology. Celiac disease is more commonly found among white Europeans or those of European descent. It is recognized as a common disorder that can be diagnosed at any age, but commonly occurs at age of 1 to 5 years old. Estimates vary from 1 in 5,000 to as many as 1 in every 300 individuals. Celiac disease is 20 times more common among type 1 diabetes patients than in the general population, that it became recommended to apply screening programs for celiac disease among children recently diagnosed with type 1 diabetes. Pathogenesis of celiac disease, genetic predisposition and environmental triggers, dietary and non-dietary. Pathological spectrum of small intestine. The classic pathology changes of celiac disease in the small bowel are categorized by Marsh classification. Marsh stage 0 normal mucosa. Marsh stage 1 intraepithelial lymphocytes greater than 20,100 enterocytes. Marsh stage 2 proliferation of the crypts of Leverkusen. Marsh stage 3 partial or complete villus atrophy. Marsh stage 4 hypoplasia of the small bowel architecture. Clinical presentation of celiac disease. The most commonly recognized symptoms of celiac disease relate to the improper absorption of food in the GIT. Patient present with diarrhea, less than 50%, steatorrhea, flatulence, distended abdomen, weight loss, and generalized weakness. Up to 38% of patients are asymptomatic. Unrecognized celiac disease may cause malabsorption, iron deficiency anemia, osteoporosis, osteomalacia, causing bone fractures, pain, and bony deformities. People with celiac disease may also experience lactose intolerance due to lactase enzyme deficiency. Dermatitis herpetiformis. Dermatitis herpetiformis is the skin manifestation of celiac disease. It is an intensely itchy rash that occurs in the hands, fingers, forearms, buttocks, or scalp, or anywhere on the body. The rash typically consists of intensely itchy small red dots that may develop into blisters or pimples. Approximately 10% of patients with celiac disease have dermatitis herpetiformis, and it is estimated that greater than 85% of patients with dermatitis herpetiformis have celiac disease. Celiac disease in the lung. The association between celiac disease and diffuse interstitial pulmonary disease has been suspected since 1970. Extensive allergic alveolitis was found in combination with celiac disease, and it may be considered that both these diseases are based on one common immunologic disorder. The association between pulmonary hemocirrhosis and celiac disease have been reported 9 times in literature as an extremely rare combination. Other presentations of celiac disease: neurological symptoms, peripheral neuropathy, ataxia, or epilepsy. Aphthous ulcers in the mouth is considered to be an autoimmune disorder associated with celiac disease. Dental enamel defects are frequent. Patients with celiac disease may have liver diseases. Abnormal liver tests are common at diagnosis and usually improve with treatment. Diagnosis of celiac disease: serology, serum immunoglobulin A endomysial antibodies, and serum immunoglobulin A tissue transglutaminase antibodies have both sensitivity and specificity greater than 95%. Testing for gliadin antibodies is no longer recommended because of its low sensitivity and specificity for celiac disease. The tissue transglutaminase antibody is the recommended single serologic test for celiac disease screening. Small bowel biopsy, required to confirm the diagnosis of celiac disease, should also be considered in patients with negative serologic test results who are at high risk or in whom the physician strongly suspects celiac disease. Mucosal changes may vary from partial to total villus atrophy, or may be characterized by subtle crypt lengthening or increased epithelial lymphocytes. To avoid false negative results on endoscopic biopsy, it is recommended to obtain at least 4 tissue samples to increase the sensitivity of the test. HLA genetic typing, antibody testing, and HLA testing have similar accuracies. Test HLA-DQ2, 94% sensitivity, 73% specificity. HLA-DQ8, 12% sensitivity, 81% specificity. Differential diagnosis of celiac disease: anorexia nervosa, autoimmune enteropathy, bacterial overgrowth, collagenous sprue, Crohn's disease, giardiasis, HIV enteropathy, hypogammaglobulinemia, infective gastroenteritis, irritable bowel syndrome, ischemic enteritis, lactose intolerance, pancreatic insufficiency, soy protein intolerance, tropical sprue, tuberculosis, Whipple's disease, Zollinger-Ellison syndrome, intestinal lymphoma. Dietary management in celiac disease. At present, the only effective treatment is a lifelong gluten-free diet. No medication exists that will prevent damage or prevent the body from attacking the gut when gluten is present. Strict adherence to the diet allows the intestines to heal, leading to resolution of all symptoms in most cases, and depending on how soon the diet is begun, can also eliminate the increased risk of complications. Refractory disease. This may be because the disease has been present for so long that the intestines are no longer able to heal on diet alone. The patient is not adhering to the diet because the patient is consuming foods that are inadvertently contaminated with gluten. In this case, steroids and immunosuppressants should be considered. Experimental treatments. Genetically engineered wheat species are wheat species that have been selectively bred to be minimally immunogenic. A combination of enzymes, prolyl endopeptidase, and a barley glutamine-specific cysteine endopeptidase that degrade the putative 33-mer peptide in the duodenum. This combination would enable celiac disease patients to consume gluten-containing products.